Now we come to our last talk. It's by Dr. Andra James. She professes to be an OBGYN, but I think she's really a hematologist, or an honorary hematologist. And I think everybody knows Andra James. Dr. James is the director and founder of Women's Hemostasis and Thrombosis Clinic at the Duke University. She's also the president of the Foundation for Women and Girls with Blood Disorder. She works with federal agencies, with hospitals, with clinics, with physicians, hematologists, everybody, and I think has raised awareness along with other people about women's issues and blood disorders. And so thank you, Andy, for doing that. And we're welcome to hear her talk, which is very timely, Contraception for Women with a History of Thrombosis.
Thank you, Roshni. I hope you can all hear me. And thank you very much for your attendance at this symposium. I also want to thank my colleagues for their wonderful presentations, and I want to thank our sponsors for making it possible. I'm going to talk to you about contraception for women with a history of thrombosis. I have these disclosures. I have many others, but they're personal. By way of overview, I'm going to speak on contraceptive options in general, the risk of thromboembolism with hormonal contraceptives, contraceptive options for women with a history of thromboembolism. I think sometimes we forget that there are contraceptive options other than hormonal contraceptives. And I want to talk about women who should not get pregnant, period. There are some of those. And thromboprophylaxis at the time of surgical sterilization for those women who have been advised that they should not be pregnant or choose themselves not to be pregnant. Now, I don't want this to turn into an OBGYN lecture. Even my OBGYN residents don't want to hear me lecture on OBGYN, but they'll talk about, you should be aware that these are somewhat ordered in ranked by degree of effectiveness. Periodic abstinence has its obvious limitations. Beyond that, then we have spermicides. That's a chemical contraceptive, and it comes in the form of foams, creams, suppositories. They're available without a prescription in pharmacies. Then there are the barrier methods. The one that's known best is the male condom, which is available in pharmacies and vending machines. Then there's the diaphragm, which does require a prescription and needs to be fitted to each individual woman. And then the cervical cap is not used very often, at least here in the United States. Then we have combined hormonal contraceptives, and they come in the form of pills, patches, and a vaginal ring. Then we have progestin-only contraceptives, and you've heard them alluded to already today. We have progestin-only pills. We have the depomedroxyprogesterone acetate injections, and I'm used to using the brand name, which I'll refrain from. And I must say that any reference to brand names today by any of our participants was inadvertent. We don't endorse any particular brand of anything, the foundation that is. Then we have a subdermal implant and the levonorgestrel intrauterine device. In addition to the levonorgestrel intrauterine device, there is a copper intrauterine device on the market, and then there is permanent sterilization for both men and women. Now, this slide has contraceptive methods, again, ordered by effectiveness. Contraceptive methods in general reduce the risk of pregnancy by 85%, and proper use of the most effective methods can reduce pregnancy by 99%. And what is helpful to know for your practice, if you have a patient who needs effective contraceptives immediately, that a spermicide and condoms used together are as effective as sterilization or an intrauterine device or pills. so that if you have a patient who needs immediate and completely effective contraceptives, they can over the counter get condoms and spermicide and use them together. Now, there are considerations in the prescription of contraceptives, for instance, permanent versus reversible for the adolescent and the young woman of childbearing age. She probably doesn't want a permanent method, but a woman who's achieved her ideal family size may want something permanent. Then there's the locus of control. A woman may not be comfortable with a man being in control of the condom. Then there is the issue of intermittent use versus constant use. I meant to say constant, not condom use. The intermittent use is not always convenient. And then there are other benefits from contraceptives, like the barrier methods and spermicides may provide some benefit in terms of transmission of sexually transmitted disease, and the condom provides very good protection from transmission of sexually transmitted disease. There are systemic effects of the hormonal contraceptives, some good, some bad. The good effects or positive effects that we've discussed here today include reduced menstrual blood flow, and along with that, there is reduced risk of ovarian hemorrhage at the time of ovulation with combined hormonal contraceptives. But the flip side of that is an increased risk of thrombosis that's also been alluded to. Now, these are data from the Centers for Disease Control. These are the popularity of various contraceptive methods from the years 2006 to 2008, the latest data that were available. And you can see that the most popular methods in the United States, and this isn't true in other parts of the world, but in the United States, the most popular method is the combined hormonal contraceptive pill, followed by surgical sterilization. Now, the combined hormonal contraceptives, as I mentioned, comes in the form of pills, patches, and rings. And the progestin-only contraceptives, as we've already discussed, come in the form of pills, injections, subdermal implants, and the intrauterine device. And that's what we think of most commonly in terms of putting women at risk for thrombosis. Now, combined hormonal contraceptives contain an estrogen and a progestin, and the estrogen, until very recently, was estradiol. There's finally a new estrogen on the market, a natural estrogen, but historically the estrogen has been estradiol with a progestin, and the progestin differ in chemical structure, but the estrogen is the same. And these progestins may differ may confer differing risks with respect to thrombosis. Also, the risk of venous thromboembolism may vary according to the study, according to the dose of estrogen, as well as the type of progestin. In various studies, the relative risk of venous thromboembolism has been reported to be anywhere from 2 to 6-fold. And the absolute risk has been reported to be 20 to 40,000 per 100,000 women years with combined hormonal contraceptive pills, 40 to 50 per 100,000 women years with the contraceptive patch, compared to a background rate of about 20 per 100,000 women years for the population as a whole. You may have seen the two reports in Lancet this past spring with the drospirenone progestin pill compared to the levonorgestrel pill. In those studies, they found that the drospirenone combined hormonal contraceptive pill had a background risk of 20 per 100,000 women years, as compared with 10 per 100,000 women years with the levonorgestrel combined hormonal contraceptive pill. Now, progestin-only pills, no matter whether they contain the progestin norethindrone or levonorgestrel, are not associated with an increased risk of thrombosis. Now, the levonorgestrel intrauterine device is not associated with an increased risk of thrombosis, but there is some controversy about whether the depomedroxyprogesterone acetate injections may or may not be associated with an increased risk of thrombosis. The World Health Organization collected data for both oral and injectable progestin-only contraceptives and did not find an increased risk of stroke, venous thromboembolism, or acute myocardial infarction with the progestin-only contraceptives, either pill or the injectable form. But in a recent study published by the Leiden Group, they found a 3.6-fold increased risk of thrombosis with the injectable depomedroxyprogesterone acetate injections, did not find an increased risk of thrombosis with the levonorgestrel intrauterine device. We have not altered our practice yet, and we continue to offer progestin only contraceptives to women with a history of thrombosis. Now, the Centers for Disease Control of the United States have adopted World Health Organization medical eligibility criteria for contraceptive use. And they have grouped their recommendations by category. And these categories of guidance are 1, 2, 3, and 4 here, with 1 being no restrictions on the prescription of certain contraceptives. 2, benefits generally outweighing risks. 3, risks usually outweighing benefits. And 4, the risks being unacceptable for a particular method in a particular situation. And this is the guidance that the Centers for Disease Control has issued for combined hormonal contraceptives, and that includes pills, patches, and rings. The guidance has classified the risks as unacceptable, not a surprise, for combined hormonal contraceptives for women who have acute venous thromboembolism or a history of venous thromboembolism on anticoagulant therapy with less than 3 months of therapy and at high risk for recurrence, or a history of venous thromboembolism and not on anticoagulant therapy. And then they classify risks usually greater than benefits for women who have been on anticoagulant therapy for more than 3 months or have a history of venous thromboembolism or not on anticoagulant therapy and no risk factors for recurrence. Now, they furthermore find the risks unacceptable to maintain women on a combined hormonal contraceptive if they're going to undergo major surgery and have prolonged immobilization, have thrombophilia, have a history of ischemic heart disease, or a history of stroke. But they generally consider the benefits outweighing the risks if there's going to be major surgery without prolonged immobilization, there's only a family history of thromboembolism, or only superficial thrombophlebitis. And no restrictions for women with varicose veins or minor surgery without immobilization. Now, these next couple of slides refer to the guidance for progestin-only contraceptives. Now, I see some of you taking notes. I'd also like to let you know that this entire presentation will be archived on our website after a certain number of days, and it'll take us a while to get it there. But we'll want you to have all of this information available to you in the future. Plus, we'll be more than willing to make our slides available to you. So after that footnote, these next couple slides refer to the guidance for progestin-only contraceptives. The benefits are generally considered to outweigh the risks for women who've had acute venous thromboembolism or a history of venous thromboembolism or thrombophilia or a history of a heart disease or a history of ischemic heart disease or a history of stroke. There's only that asterisk there. There is some concern on the part of the Centers for Disease Control that women that take the depomedroxyprogesterone acetate for a long period of time may have alterations in their LDL cholesterol, and that's what that qualifier is there for. And then the benefits are generally considered to outweigh the risks for women who will have prolonged immobilization with major surgery. And no restrictions for a family history of thromboembolism, major or minor surgery without prolonged immobilization, varicose vein, superficial thrombophlebitis. So in general, in summary, the Centers for Disease Control it would endorse progestin-only contraceptives for women with a history of thromboembolism. Now, what the Centers for Disease Control added that the World Health Organization does not include in their guidance is a qualifying statement recognizing that sometimes there are situations where combined hormonal contraceptives or hormonal contraceptives are used to manage reproductive tract bleeding, heavy menstrual bleeding, or to suppress ovarian function, where the hematologist and the gynecologist are between a rock and a hard place, and they're trying to manage a situation that was posed in that question to Dr. Smith's Whitley after the last session. So this statement that's included in the guidance, women on anticoagulant therapy are at a risk for gynecologic complications such as hemorrhagic ovarian cysts and severe menorrhagia. Now, hormonal contraceptive methods can be of benefit in preventing these complications. When a contraceptive method is used as therapy as opposed to contraception, it may alter the risk-benefit ratio. So decisions need to be made on a case-by-case basis. So in other words, we may liberalize what we would consider the risk-benefit ratio to accommodate the fact that women may need combined hormonal contraception or progestin-only contraception for management of other reproductive tract bleeding. Now, women who are on long-term anticoagulation for prevention or treatment of thrombosis are at risk of hemorrhagic ovarian cysts. Now, there's very little bleeding at the time of ovulation in most women, but women with an underlying bleeding disorder and women who are on long-term anticoagulation are at risk of having significant bleeding from an ovarian follicle that can result in a hemorrhagic ovarian cyst in the ovary or intraperitoneal bleeding or bleeding into the broad ligament or bleeding into the retroperitoneum. In a series out of Israel, half of the ovarian hemorrhages that presented at an institution could be attributed to warfarin therapy. So there are ways to prevent ovarian hemorrhage, and that is to suppress ovulation. Now, estrogen inhibits development of the ovarian follicle, and progestins inhibit the actual ovulatory process or ovulation. Now, low-dose combined hormonal contraceptives may allow development of the dominant follicle during that 7-day hormone-free interval. Shortening that interval to 3 to 4 days can reduce follicular development. So can the use of monophasic, meaning one formulation, as opposed to the biphasic or triphasic pills that we commonly prescribe. Now, depomedroxyprogesterone acetate injections and the subdermal implant can also suppress ovulation, but the progestin-only pills don't consistently suppress ovulation, and the levonorgestrel intrauterine device does not suppress ovulation. Now, that's the bad news. The good news means that it doesn't have the same effect on bones that the depomedroxyprogesterone acetate does, and there's no black box warning about it, but it does not suppress ovulation. So, in summary, in terms of hormonal contraceptives that protect against ovarian hemorrhage, yes, for monophasic combined hormonal contraceptives, especially if they're recycled after 3 to 4 days rather than the 7-day hormone-free period, depomedroxyprogesterone acetate injections, and subdermal implants. But no to progesterone-only pills or levonorgestrel intrauterine device. Now, there are some women who we should take a slightly paternalistic attitude toward because they should not be pregnant. And there are women with some thromboembolic conditions who should not be pregnant. Most women who have a history of thromboembolism can be counseled that yes, their pregnancy may be high risk, but with prophylactic anticoagulation or good surveillance for them and their unborn baby, the pregnancy may be high risk, but they can be managed and be taken safely through it. But there are some women for whom that's not true. Their condition puts them at unnecessary risk. And they are women who have recurrent thromboembolism while fully anticoagulated. Now, a woman who is having recurrent thromboembolism while she's fully anticoagulated and then becomes pregnant is going to have a 4 to 5-fold increased risk of thromboembolism superimposed on her already high risk of thromboembolism. So she should probably not get pregnant. So should the woman who has chronic thromboembolic pulmonary hypertension. And it's not because of her thromboembolic risk, but because pulmonary hypertension is not well tolerated in pregnancy and is potentially lethal. A woman with a history of myocardial infarction has a 5% risk of recurrence during pregnancy, and that carries a 5% mortality rate if she has a recurrence. Women with mechanical heart valves have a 10% risk of mortality during pregnancy. Women who have permanent occlusion of a major abdominal or pelvic vessel may not have the blood supply for themselves or their unborn baby to get them safely through pregnancy. And women with paroxysmal nocturnal hemoglobinuria have all sorts of potential bleeding and clotting problems, as well as are at high risk for severe preeclampsia, HELP syndrome, and other complications of preeclampsia. So there are women who are on long-term anticoagulation with warfarin should probably avoid pregnancy while taking warfarin. There are some exceptions, but in general, women who are taking warfarin are at risk of miscarrying, increased risk of miscarriage if they conceive while they're on warfarin. Depending on the series, the risk has been reported as anywhere from 15%, which is the background risk of miscarriage in the general population, up to 56%. There's an increased rate of congenital anomalies in women who conceive or take warfarin through the first trimester, and women who take it later are at increased risk of bleeding or stillbirth, and there are reports of neurologic sequelae in women who take it throughout pregnancy. Now, for women who elect sterilization, I recommend, because of their thrombotic condition, I recommend vasectomy. You think I'm kidding? It's not, it's not always accepted by the person who has to undergo the vasectomy. So that seems to be a locus of control issue that I alluded to earlier. So then we get back to the tubal sterilization issue. And so there are issues regarding thromboprophylaxis for the woman who is undergoing permanent sterilization. We do have methods of sterilization now that don't necessarily involve surgery. There are now two methods that can be done intravaginally. But for women who undergo conventional sterilization with a laparoscopic procedure and are not on long-term anticoagulation, they should probably receive additional thromboprophylaxis with one or more of the methods described below. The CHEST guidelines suggest that for gynecology patients undergoing entirely laparoscopic procedures in whom additional VTE risk factors are present, they recommend the use of thromboprophylaxis with one or more of low molecular weight heparin, low-dose unfractionated heparin, intermittent pneumatic compression, or graduated compression stockings. And these are completely congruent with the American College of Obstetrician and Gynecologist guidelines, which would regard this as a moderate risk situation. In other words, a patient who has had a history of thrombosis, who is not currently anticoagulated, that would be a moderate risk situation, because this would be surgery lasting less than 30 minutes in a patient with an additional risk factor. And they would recommend low molecular weight heparin, low dose unfractionated heparin, intermittent pneumatic compression, or graduated compression stockings. Now, in the patient who's going to undergo sterilization who's fully anticoagulated, the CHEST guidelines would recommend that this patient be bridged to low molecular weight heparin, and they recommend the use of subcutaneous low molecular weight heparin on an outpatient basis, with the patient receiving the last dose of low molecular weight heparin 24 hours before surgery and resuming their low molecular weight heparin approximately 24 hours afterwards, with a judgment made on an individual basis as to whether that could be started sooner or whether it should have to be delayed later. So in summary, this morning we've reviewed contraceptive options, the most effective being the implant, intrauterine device, sterilization, pills, and tubal sterilization. We've reviewed the thromboembolic risks of combined hormonal and progestin-only contraceptives. We've addressed the issue of women on anticoagulant therapy and their risks of gynecologic complications such as menorrhagia and hemorrhagic ovarian cysts. And we've reviewed how hemorrhagic ovarian cysts can be suppressed. And we've reviewed how to provide thromboprophylaxis for a woman undergoing permanent sterilization. And I want to thank you very much for your attention, and I hope you've enjoyed this symposium.
Thank you very much. This is open for questions. Please come to the...
Yes, I have a question. You made the point very thoroughly that progesterone-only oral pills are not associated with an increased risk of thrombosis, yet with estrogens they are. When you compare the second and third generation pills, isn't there a change in the oral progesterone component? Why would that be associated with an increased risk with the third generation versus the second if all that's changed is the oral component of the progesterone?
So if I understand the question correctly, if a progestin-only contraceptive does not increase the risk of thrombosis, why can we change the progestin and increase the risk of thrombosis?
Exactly.
I don't know. And, but there are, this is a compelling question and gets at the biology of thrombosis And in fact, the National Heart, Lung, and Blood Institute is convening a working group on hormones and thrombosis sometime in the future, and that's actually one of the questions that they're asking experts in the field to address, because I think it gets at some of the underlying biology.
Thank you. My name is Dupiela Beauty. I'm a hematologist from King's College Hospital in London, and I look after one of two of the national centres in the UK that looks after patients with paroxysmal nocturnal hemoglobinuria. I just wanted to make a comment about your point about women not getting pregnant with PNH, which was indeed what we used to advise them. Fortunately, things have moved ahead a little bit since then. And in particular, there's been the development of a new drug which blocks complement at C5 called eculizumab or Soliris. And because of the use of eculizumab, we've managed to reduce the risk of not just hemolysis, transfusion requirements, and thrombosis in these women. There's been a report in the literature of 7 pregnancies from one institution managing this woman on the drug from the second trimester in pregnancy together with low molecular weight heparin from the time that they get pregnant. And 5 women, and I think there were 7 pregnancies because one was a twin. But also in our center this year, we've had 2 women deliver babies, healthy babies, normal size, at full term, managing them with this new drug. So for patients who are, have access to this drug, certainly things have changed in terms of PNH. So might want to sort of slightly alter your slide before it goes into the public domain.
That's very exciting. Thank you very much for the
Can
update.
we go to the back and then come back to the front?
What do you recommend for for a lady who has mechanical valve and insists to get pregnant? What will be the best recommendation regarding anticoagulation if she gets mechanical valves?
Okay, so the question is, what do we recommend for anticoagulation for a woman who has mechanical valves? That's a whole nother talk, but I'll give you the short version. There are differing risks depending on whether she chooses, depending on what risks she's willing to take. In general, as you're probably aware, there are lower maternal risks of thrombosis if she continues on
Warfarin?
or the oral vitamin K antagonist. But there are decreased fetal risks if she stays on low molecular weight heparin. We actually counsel the patient about all the risks and allow her to make the decision at our institution. It's sort of interesting how patients sort. If it's their first baby, they tend to choose the low molecular weight heparin option. If they have other children, they tend to not want to risk their own life, take as many chances with their own life, and they tend to choose the warfarin option.
Thanks.
Kathy Hassel?
Kathy Hassel, University of Colorado. Much appreciated, Andy, and nicely done. 12 times a week in Thrombosis Clinic, these questions come up for many of us. I have 2, because I'm a believer in offering women information versus our speculation. So 2 areas of perhaps you've run across with old data. What is the risk if you take the pill again after clotting the first time? And I mean, it's a duh moment, my teens would say, but really, I don't know since thrombosis is multifactorial. And secondly, how much is that risk mitigated if you take estrogen-containing contraception and remain on therapeutic anticoagulation?
Okay, so ask the second question again.
So the
Because I have
second,
attention deficit.
No
But
worries.
ask
How about the first one?
Ask the second question after I answer the first one. So
Yes.
I think that we can say that here's how I would answer the first question. A combined hormonal, I think that you are good at calculating or fairly good at calculating what your risk of recurrence is for your individual patient in clot clinic. You can figure if they take a combined hormonal contraceptive, you increase their risk 2 to 3-fold.
Got it.
If they're at a very, very low risk, is that worth increasing it 2 to 3-fold above that? That's how I would counsel them in that situation.
Thank you very much. The second question is if they say, well, I want to stay on estrogen-containing, perhaps for medical reasons, contraception, how much is that risk mitigated by remaining on anticoagulation? What's the rate of clotting if you're on warfarin and estrogen?
So we don't really know. We don't have data about that. And is there, are the factors can we measure the degree to which estrogen affects the overall clotting scenario and assume that we've compensated for it by INR? I don't think so. So I don't think we know that. But it's certainly a situation where we feel comfortable prescribing a combined hormonal contraceptive to a woman who's fully anticoagulated if she's not at a high risk for recurrence.
Thank you.
Go ahead.
Hi, Andy. Thanks for the great talk. Evelyn Lockhart from Duke. So recently, in fact, I think it was this week, I had seen something on a different approach to tubal ligation where it was actually a thin catheter and it was an intraluminal approach to the fallopian tube, a little silicone plug. Is that something that you would consider for these patients that have a history of thrombosis and the increased risk for thrombosis with laparotomy and the need for increased thromboprophylaxis?
Yes, that is one of the new intravaginal methods, and the other involves a little spiral coil. But one or the other reduces the need for abdominal surgery, and our patients are candidates for it.
Hi, my question relates to the difficult patient, the young woman who is asymptomatic but has a family history of thrombosis and now has been tested and found to have a thrombophilic risk factor. If I pick the lowest one, like a heterozygous factor V Leiden, and now I'm specifically going to just ask one question related to that. If that young woman is already on a combined oral contraceptive for greater than 1 year and now was tested because her mother or father had something and found to be positive, how do you counsel them? Do you tell them to come off that combined even though they've had no events and they're, under 35 and make a switch to an IUD or a progestin-only, or do you utilize that history that they haven't had an event early on and continue?
So,
because we're seeing a lot of these patients
that's right.
now.
And I think that how this situation might be handled, I think there's an attorney in the room. I think we have an attorney on our board of directors. Is she still here? Because is she still here? Okay, well, forgive me. Because I think that how this is handled may differ by country. I think that we had a nice article in, was it Blood or JTH, by our Dutch colleagues, demonstrating that this is, maybe a low-risk situation. Although this patient actually has 2 risk factors now. She has a family history, and she has the genetic thrombophilia. And we know from some work that that's a little higher group than the patient who was discovered to have thrombophilia on population screening. Our CDC guidance would advise us, even in an asymptomatic thrombophilia, not to prescribe combined hormonal contraceptives in that situation. The risk is probably low. We start with, depending on her age, her background risk of having a clot is somewhere between 1 in 10,000, 1 in 1,000. If this is like factor V Leiden, that now we increase her risk by 5 to 10-fold. And now if we prescribe a combined hormonal contraceptive, whether she's been on it or she continues it, she continues to be at risk as long as she takes it. So we probably double or triple that. And quite frankly, in this country, there's an enormous amount of litigation related to contraceptives. And the first thing that we see when we go online for a contraceptive, is the sites soliciting
Yeah, lawsuits, right.
yeah, so when we get that patient, we suggest she use a progestin-only contraceptive or an alternative method. When she gets pregnant, there's no other way to be pregnant. She's going to be subject to estrogen then. But there are other methods of contraceptives. There are other contraceptive methods, and we would counsel her. Now, maybe she'd find somebody who would prescribe her the combined hormonal contraceptive, but we would recommend against it for medical and legal reasons.
Okay, say for the asymptomatic patient that my gynecology friend draws a factor V Leiden on, it's heterozygous, she has a positive family history of clot. So that scenario, and the patient comes to me and says, well, should I be on contraceptions? I don't want to get pregnant. She decides, okay, she doesn't want to take that risk, and now she's pregnant. So her risk is even higher of DVT and pulmonary emboli. And now the gynecologist wants to know, should we put her on prophylactic Lovenox?
So her risk of having a clot during pregnancy is about 1 to 2%, and that's probably the rate of bleeding complications with pregnancy. So that's probably, if she has no other risk factors, that's probably not enough to justify thromboprophylaxis during pregnancy, but at the time of delivery, her risk increases another 5-fold. And so probably she may need some prophylaxis at or in that immediate period after delivery, but not during pregnancy. Although the gynecologist may want to do some what we would call low intensity fetal surveillance to protect because of the fetal risks.
So you would dissuade that patient from using combined oral contraceptives in favor of progesterone, but if she became pregnant, you would dissuade that patient or her physicians from using prophylactic Lovenox until the peripartum period.
So it depends on whether she has other risk factors or not. Yeah.
Heterozygous factor V Leiden, positive family history, mom had a clot during pregnancy.
No, unless her risk was higher than the 1 to 2% because of the bleeding risks associated with a low molecular weight heparin, that would be what our guidance from the American College of Chest Physicians, the American College of Obstetrics and Gynecology would suggest.
But with 40 milligrams a day, a bleeding risk of 2%?
That's what the published data are. Until we have different data, that's what the data are.
Okay.
Andy, thank you. Going back to that patient, Alice's patient, what about the other option of going to a second generation OC, say at least that has, levonorgestrel containing? Is that an option if you have an asymptomatic? These people all of a sudden get, screened because of the family history. They've been on, say, a third or fourth generation, without incident, and really don't want to come off. Obviously, there isn't much data, but there is a suggestion, right? The second generation is less prothrombotic.
So I think that the patient then I think that's not unreasonable to do. Certainly, then we could cite to the patient how low the risk is, and I think that there are some people who would be comfortable doing that. And that would be the best of the combined hormonal contraceptive options.
And could you also clarify, despite the Dutch study, you are not shying away from progesterone use in someone with known thrombophilia?
Correct.
Okay, because I think that is a compelling study, though I know the MRC database and others historically have not shown that.
Yeah, I think we need a little more corroboration there.
And then lastly, another common scenario we see is that there is this family history, so they get screened and they have this borderline low protein S level. And this is while they're on, OC. And we know OCs can lower the level somewhat to whether it lowers it to a degree that's pathogenic, but what do you do with these, levels of 45 to 50%? Right, repeat until normal is what I would typically do.
I think that's an excellent advice.
But when we do that, and it's repeated again in that range of 45 to 50%, again, what is your sense? Is that truly a risk factor for thrombosis? I personally don't think so, but...
Well, I'm going to consult with you, and I'm going to accept that
Oh,
answer.
great.